Thank you for joining. This is Live with Miami's Community News, and I'm Michael Miller, and our guest today is Rosario Isasi. Did I get it right?
No, it's
No.
Isasi.
Isasi.
It's
Okay, there you go. Isasi. I practiced about 20 times. All right. Isasi. Okay, folks, that's going to be the end of it. All right, Isasi. Okay. And she is a research associate professor at University of Miami, All of Us Research, all right, which is an important issue, especially when we see what's going on with the pandemic. And it's really made us think about all the different types of testing and vaccines that's been going on and how we become a healthier country. So I'm going to read a little bit about her resume here, and a little bit about her. It's very impressive. All right. You're pretty smart here. All right. So let's see. You are devoted to identifying and analyzing social, ethical, and policy dimensions of novel and disruptive genetic technologies. I'm not sure what that means, but we're going to find out a little bit about it. You have your law degree from Pontificia Catholic University of Peru and a master's in public health from Boston University. You got a lot more degrees here, a lot of education. You teach at the medical school. You're going to be teaching soon at the law school there. So let's talk about some things you're working on and why it's so important to understand what you and the university does.
Okay, so first, I'm a lawyer by background, and I'm an ethicist by vocation and by training. So my work is work on a field of study that normally we call it ELSI, is the acronym for ethical, legal, and social issues. What we do is we identify what the ethical, the moral issues and implications of research, of science, and how they affect individuals, communities, and society. So we work in asking the question of what should we do rather than what can't be done. See the difference in the ethics and the moral aspects?
25 years ago, there was a gentleman out on the coast. I've actually forgotten his name. He assisted in suicides, right? And I come from a health background many years ago. And when we were faced with that issue of life and death and what you do, all right? And Jack Kevorkian,
yes,
right?
I know him. Yeah.
Right. And so you look at it, he brought forth so many things, all right, to question what we are about as humans. And some of the countries around the world have said, if somebody doesn't want to be with us anymore and they meet certain criteria, maybe that's your choice. Well, let's talk about now the All of Us research program and what does it mean and what are you trying to accomplish?
Well, first, I want to touch on the issue of the Kevorkian because from death I want to move to life, and that's the All of Us program, right? At the core of bioethicist is kind of like the questions you pose: what it means to be human, right? And how human we're gonna be, meaning how advances in science from the bench, from the research to the bedside, to the clinical applications will affect the values that we hold most dear. The All of Us program, I think, continues that path of evolving, of having science working alongside with ethics, right? And moving from a paternalistic view. So what it was science before? How was medicine before bioethics? And what bioethics trying to fix? Is thinking they know it all, right? The doctor, the researcher knows it all. And then the autonomy, linking your one of the clinical ethics issues more thorny in bioethics, life and death and co-working, with the All of Us is autonomy, is letting people decide, right? And participate in research. The All of Us, I think, is the most revolutionary study the US have ever had. And the scientists will tell you because of the science, right? Precision medicine, etc. As a bioethicist and a lawyer, I will tell you is because inclusion. Because it's the first time in the United States, there's a big study that equalizes, that invites everybody at the table to participate, to be a member of this huge research team. But not only you are sitting at the table, but we have the opportunity, like here, to talk, to be heard, to be understood, and to be respected for our opinion.
So let's focus in on the All of Us program and the purpose of it and what you're trying to accomplish. And then I would like to talk about how people got in line to get the vaccine and how some people didn't get in line but got the vaccine. And for the simple guy like myself and around the community, is jumping the line right? Is it wrong? And where do you start dividing that and say, well, because of this and because of that, we did that. So let's go again and work on the All of Us program. And what's its purpose? And what are some of the projects that you're working on?
So the All of Us research program is a pioneer research institute. It's a long cohort study that looks at advances in precision medicine. So meaning that one day we can have a tailored intervention. It's research. We want to advance knowledge. And we want to fill a gap in research. I mentioned before this ethos, this culture of inclusion. All biomedical research, as we know it, have been built on two things. One is a population that is being widely white of European ancestry, meaning that some of the discoveries could be biased and could not be applicable to me. Maybe aspirin for a Latina does not have the same effects, or a cardiovascular disease medicine, because it had not been fully studied in our population. And the two that I want to link later with your questions about hesitancy to participate in research or in medicine, right? Uptake medical breakthroughs is being disenfranchised.
One of the things that you brought up, but in the United States, the testings were done on the population at that time. Correct? Meaning if it was, 50 years ago, if the population was X% Anglo, all right, and X% from European, this would be, the testing was done on them. But as the population changes, is that what you're saying?
No, it's not like that. It's worldwide. There was always this inequities that Caucasians, white of European ancestry, that tend to have higher socioeconomic status, were those that were the doctors, and therefore the representation for research was the same. They were invited. We left behind those that we felt it didn't feel this 1% or 30%, whatever was the percentage of the population. It doesn't mean that quantitative, they were more white or Caucasians or European ancestry. It means that intentionally we left them behind. And we use them, and I'm used purposely as an ethicist, the term use, minority populations for unethical experiments, those that we will not allow to use.
There is some evidence to support that.
Yes.
A bunch.
Right. The Tuskegee experiments, the Henrietta Lacks, the Hasupavai tribe and Native Americans, more or less, the Guatemala experiments, from which there have been presidential commissions and apologies for that.
Would you care to share how that might have affected how people in Miami-Dade County receive medicine over the last 50 years?
It affects tremendously because there's this hesitancy, this mistrust, right? If you do not only abuse people or intentionally leave them behind or exploit them and not invite to the table, then the story of why you include me now, what you want from me, right? And it's human. It's that very raw human sentiment.
And that still lives today.
And it still lives together. It's a legacy of the past. And people like me, bioethicists, we try to work on that. Good science starts with good ethics. And that means creating that culture.
In the early 60s, poor people, mostly people of color in Homestead that didn't have money, could not go to James Archer Smith Hospital, could not go to the other hospital down south. They had to spend the 20 to 30 minutes to go to Jackson Memorial Hospital. I'm sure there are plenty of patients that didn't make it in that transportation.
Absolutely.
And so came Community Health of South Dade, and with many locations and serving the underserved. And certainly we saw that during the distribution of the vaccine. Can we talk about the vaccine?
We can talk a little bit about vaccine. I would love to talk about organs, but I see a connecting point with the vaccine and participation in all of us.
So we were all acutely aware of when the vaccine first came out that there were plenty of people that were making donations and getting shots. That was commonplace, right? And when I looked at it, you begin to realize that just demonstrates and that duplicates life. Meaning if you want it free, go wait in line. But if you have money, you can go over here and not wait as long, right? And so when we watched it happening mostly in the poor areas in Liberty City and in Carroll City, parts of South Miami, South Dade, Homestead, Florida City, the county did step up. And so did CHI. So we're going to take the medicine to the people, right? Yeah. but I still see the hesitancy with lots of groups that are afraid, right? They're afraid it's a plan, it's afraid it's a conspiracy. They're not quite sure. They don't have trusted advisors with that. And so they get the disease, and then they get sicker, and then their families suffer, and then all of us suffer financially from that. So one of the things that I've recognized by ripe young age is that I think the best way to describe it, somebody wanted to talk about socialism here in Miami-Dade County. And I said, I can't talk about that, but what I can talk about is the African Americans need help. I have white privilege. And what are you going to do to take care of us on a federal level? Once you recognize that, your position that you were given because of your birthright and the color of your skin and your intelligence and a lot of where you went to school to help you move that along, it makes you start thinking about those people that are deathly afraid of getting a vaccine, even though that they know the numbers, but they're certainly afraid with that. And I think that this Jackson health system has helped improve that a lot in the last 10 years. They opened up the out of West Kendall and Doral, and that's helped bring the medicine to the people.
And so University of Miami, yes.
Yeah.
There's some, and again, a common thread when you talk first, right? You talk about jumping the queue, getting ahead, right? To get the vaccine or to get treatment, parallel with lack of access to quality care or prompt care. And then we talk about all of us. What is the unifying point there, thread, is equity, right? And we are not equitable when we don't let balance in between society burdens.
So how do you get the hesitant person to participate in your program? If they're hesitant anyway, why are they going to say, I'm going to go participate in this, even though at some point it becomes very anonymous, all right?
Mm-hmm.
All right. What do you do to get them to, so that the great equalizer is there?
I will highlight the first thing. So equity is not everybody having the same. So I'm 5'2", 152, I'm short, right? If we have a wall in front of us, and you're 6 feet, and the wall is 7 feet tall. If we said, let's lower down to 6'2", that is your height, right? And Rosie tried to reach the wall, right? I would say, no, that's not equality. Yes, it is, people said, it's justice because you both can jump that wall. And I would say, give me a small ladder that makes me 6.2 so I can look above the wall. That is equity. You understand? If we both get the same steps, we are still unequal, unbalanced. If you give me a little bit more, we are the same. So how do I connect this with hesitancy and mistrust in medicine, in research, is that we are trying to fix what was wrong. We start by recognizing, by being humble and recognizing there was mistakes of the part. People were abused, historically unrepresented, etc. Especially communities of color. Now we said we are fixing it and we are inviting you in this research project. We are balancing the risk of participating in research or in life. Life is not a risk, but also the benefits. We are going to distribute it. So when people trying to jump a queue for the vaccine or something, we are creating more disparities. We are trying to fix that. How we convince the hesitant? First, inviting to be really participatory.
And what are the programs that reach out to people of color and people that are hesitant?
In general, how do I reach to the hesitant? First is that part, is asking why we want them to participate. So that fear of why suddenly you want me here is that myth of you're going to exploit me again. It's simple. Second, we make them participatory. What it means is that we are partners. In the All of Us research project, we have a number of what we call a government, so different structures within the program to make sure that if somebody signs for participating in research, they can have a voice, a vote, and their perspective will be heard and respected, understood. So I give you an example. At the University of Miami, we have a CAB, a committee, a community advisory board that encompasses, so the members are participants, members of the community, African Americans, Caribbean Blacks, Latinos, etc. And we hear what they have to say about the program. We hear what issues do we have to address to bring that wall I was talking about of hesitancy, that wall down, right? And how do I level? What little ladder do I give them to see that is that all of us, there's also every committee that establishes the policies for the program, the direction of the program, how we look at consent, privacy, etc. We have a participant there. So that's how I address mistrust.
We understand that we have unconscious bias.
Absolutely.
Right? And this was driven home to me. I used to have breakfast at a local restaurant every Tuesday. And at some point, many Tuesdays go by and 40 people show up, including an elected official. And she says to me, Michael, do you know out of the 40 people here, that 37 are men?
Yeah.
And I said, this is my circle.
Yeah.
Right? I don't like to go to breakfast or lunch with ladies. I just think that it's a whole bunch of problems. And then I realized that was me. And I said, I'm going to do better. We're going to do better. And we had to go and reach out and go out of our comfort zone and reach really hard. The next breakfast we had, there were 130 people, and an African-American got up to sing, God Bless America. And he said, this is like the Coast Guard. There's somebody from everywhere here. A proud moment for us. But it was recognizing that we do that, right?
Yeah.
Not in a many people, all right? Not in a conscious effort, right? That's what we do, right?
Yes, but exactly. We all have unconscious, and your example is the same that we are doing to set straight the medical record, to have good science that will be one day the discoveries that affect. So the All of Us program the idea is to bring scientific discoveries to the clinical side, improve health and well-being. So when you talk about unconscious bias and local representation, in your case, women might have asked, or people of color, what are you inviting me, right? So what you have to bring is trustworthiness. And it's not about having a poster child. So I'm not here because I'm necessarily a woman or a Latina. Yeah, it might look very good, right? When there's a poster like, oh my God, look how represented we are. Inclusion, and from an ethical and moral, social point of view, means that somebody have agency and is respected as a human being.
My grandkids were over at the house yesterday, and we have a little stool for my granddaughter.
Yeah.
And we have chairs like this that go up. So, and that's part of the great equalizer. So it's not this
like my wall example.
Right. And so part of it, so how does that work? I mean, if somebody's 50 years old or 60 years old and they've never trusted, they don't really go to the doctor, and they go, you want to take my blood, you want to do this. And why does somebody want to participate in your program?
As I said, it's because we are setting the record straight and we want to improve scientific record. We want to have medicines, precision medicines that will be applicable for everybody. So how we convince, you said that 50-year-old, the best way to gain trust is to feel represented. So that means that people like me, having somebody from your community, having somebody from your same background, so you can emotionally, psychologically, I will say, cognitively connect and build that trust.
And we understand that people look, first they look and they make a decision what they're going to buy, what they're going to look, what they're going to watch. We know in books or headlines, same story, different book cover will attract different, so different people. So when somebody's, let's say they feel comfortable enough to start, right? What is it if somebody says, I want to volunteer my time because I believe in this bigger picture. I want my children, my grandchildren, and my community and this United States and perhaps the world, all right, to know what's going on in me. So what would they do?
So what I would say, first to engage them, how do you engage them? How you make them participate? How you retain them, right? Is this trustworthiness, and is what we call a return of value. What is for the participant to that? Is research. So there will not be necessarily direct health benefits, but the benefits, the scientific breakthroughs will affect them positively and the future. That's the number one, at least for me, is knowing that my community is involved and the scientific breakthrough that will come will be for the benefit of my community because I'm represented. Two, also, you get to know a little bit about yourself when you participate in the study, right? There's surveys, there's questionnaires, etc. But you get some genetic testing, genetic analysis, and it could give me from what I call found, traits like if you like cilantro or not. My husband always said it tastes like soap. I always said that no, it's delicious. He's British, I'm Latina. So I thought it was a cultural thing. It's genetic. And then let me tell you this, the last thing is that also some of the genetic testing we will do can give important actionable so that you can act on medical information to participants if they are at risk of some genetic disorders. It's research, but the program will assure this participant they could access a doctor that can interpret and navigate or a genetic counselor those results. So that is the value. That's how you bring them in. That's how you keep them in.
So one time I had some surgery years ago, and they said, we want to send a specimens to some place, right? That felt really good to be able to say yes, right? So for the person that's really not had much medical care, how do you reach them? They're not actively really be going to the doctor. How do you get them to that point to where I want to participate? Does it happen on the doctor level? Does it happen because you're promoting it? Does it happen? How does that work?
So we try to go to the communities where they live, is how we call it, right? So we can go to community events, especially pre-COVID, to community events. We have participants that are in our advisory board that bring the message to their own communities, the church, the community side, cultural center. We have a lot of marketing campaigns, community campaigns. You see us everywhere, I hope. You see us in billboards, in bus stops. You see a billboard on the street. You see us. We go there. We socialize it, but we also publicize it to others, and we talk the community with people we work with, and we so outside the medical setting.
Right? So often we need to be able to hold somebody's hand and take them to the party, right? And many times people say, "Who's going to the party?" I said, "So and so." Okay, if they're going, I'm going to go.
Exactly.
So are there people that have participated in the survey that said, "Hey, I know somebody, I'm going to go talk to them"?
Absolutely. Word of mouth is an excellent way to engage participants. We might not recruit them all, but we engage them and we make them make the decision to participate. But also we have what we call participant ambassadors, right? As much as we have clinical champions that foster in the healthcare setting participation, we have participant ambassadors. Are individuals like you and me, like others in the community that spread the word of the importance of this program.
Since people have more access to their family history with a variety of places to do that, has that increased the openness of people to participate in these type of surveys?
In a way, there's a lot of people that want to participate when they said how decisions, right? If you are an autonomous decision, a decision for myself, you always balance unconsciously benefits and risk. What is for me and what it takes, right? And for some individuals is the ability to get this genetic testing, right? Some of them, even for the fun traits, as I call it, or ancestry, knowing your origins from the genetic point of view, and others is because this sort of clinical aspect, right? What would you learn? And your family history and the result of the surveys. And individually, one result might not be much for me when I look of, I answered the survey, I saw my family history. But when remember that all of us is a research study. And we will build something that is called the Research Hub. It's an amazing pile of valuable information to mine for different scientific aspects of research. But when I look at that aspect and I said, well, now that individual aspect about me, I see it reflected in scientific record. Why Latinos have more incidence of X and Y disease. It helps explain in context. I learn more about me. I learn more about my community. And then I feel that medicine one day could be more effective for them.
Okay, and one of the goals of the All of Us research program is to have a lot of people participating.
Yes.
What's the goal?
Well, the goal is 1 million.
Mhm.
That's the all of us goal. Recruit 1 million of participants. And it's not only 1 million, it seems like a huge number. But for me, what is more important is what is behind that million. And is that the inclusiveness. People from all walks of life, all colors, all ages, all disease conditions.
So the University of Miami is collecting data from active volunteer participants. They give samples. What type of samples do they give?
They give saliva or blood, mostly blood.
And then you start doing all this research,
samples.
right?
Yes.
And you do these surveys with them.
Yes.
Can somebody assist them with that? How does that work?
Yes. So we have our I forgot what is the new term, but our research associates, our clinical associates that help the participant navigate this cycle.
And that's an interesting point about navigation, because I'm okay on the computer, and every once in a while I'll just like get stressed out and I'll throw the phone down and say, please do this for me.
Yes.
Right. And I think that a lot of people get to that point of frustration. So you have navigators that can help walk them through.
So we have clinical specialists that help them navigate. When I talk about inclusion in the program, we mean it. Meaning that if you're not technological literate, right? If technology is scary for you, we have somebody that helps you walk through the process. Create an email, access your website, follow your surveys, and keep you engaged, but helping you make your own decisions to keep enjoying this.
So, Professor, lots of people are concerned about privacy and about being judged.
Yes.
Right? How do you deal with those things?
Those are, I think, two of the most important ethical issues and ethical concerns that participants have. Privacy, we resolve it, or we try to mitigate any privacy risk by having very secure databases that are only accessible for qualified people. Not only that, all of us and the NIH gets what is called a certificate of confidentiality. This is a process that prevents unauthorized disclosure of sensitive information outside, even coerced by the court. So privacy is secure that way. The information that gets to the research hub, the database, and all of us is de-identified, meaning you will not know that Rosario Isasi was part of the program. You see data. You don't see the names, the identifiers. And there are also risks about mistrust when you said, and what happened is the risk of discrimination and stigmatization, so labeling, considering less other people. That's another concern that we address. It's particularly important when we are recruiting participants, what we call UBRs, underrepresented biomedical research, those communities of color and others that have been disenfranchised. So the studies cannot be used against them if you wish. Right?
So, and we see how medicine and healthcare providers is shifting a little bit.
Yes.
In the sense before it was doctors were men and nurses were women.
Yes.
All right. So now you have about half the physicians are women. Mm-hmm. Is that about right?
Yeah.
All right. About half. All right. And then in the nursing arena, I don't think that the males have gotten a bigger piece, but you have nurse practitioners where we see men are elevated a little bit more. You have physician's assistants.
Yes.
And as an administrator told me once, Michael, if they would change the name of nurse to something else, they would probably get more men. And it was interesting because when we see physician's assistants, right, I haven't seen the figures on that, but we know that there's in this elevated educational system, people that are really driven, there's a lot more men and a lot more women, I might add, in doing that. So I'm proud of the system. I used to be a registered nurse a long time ago, and went to Jackson Memorial Hospital, and I thank my professors from 50 years ago, or almost, well, 40. So how important is diversity in this research to make sure that the information that you have is usable?
I think I cannot highlight enough the value of all of us in inclusiveness. And when we were talking a lot about ending minorities, we were talking about disenfranchised. You bring an excellent point that is also gender, but it's not only this binary of women, female, male, LGBT plus communities are highly involved. And from who gets to work at all of us, right? And the representation is very wide, from who gets to participate and how we tailor to the needs to that. And that's another aspect, right? Another community, LGBT plus communities that have been also disfranchised from themselves. There is a lot of mistrust from HIV pandemics and others. There's this fear of a stigma and fear not being represented. So we try to address that too. And say also, if we studied this in the communities, plus, for example.
You know, it is amazing in the last 40 years how AIDS and LGBT and all that. There's so many letters, I've forgotten how many letters there are. To see the advance that has been made. We, by the way, every once a week we have a show called Forward Miami, which is for LGBT folks.
Yes.
And one day I said to one of the ladies that was here, I said, "Your hair is gorgeous." Well, it turned out after about 10 minutes, it wasn't a lady. And it was so funny that as I walked through that process of saying, "Oh, here she is," all right, and to listen to the needs, and they are different, not just the medical needs, the whole process, the emotional needs, and the standards that we have set up in society, which is built for this type of person, this type, and it's different. And certainly when we watch commercials nowadays, and in the last 6 months especially, we see how that is advanced to be representative, and sometimes over-representative, but I get it, because sometimes you have to sit at the front of the bus, right, and make a point, which is, I need to be represented with people of all different shades and all different socioeconomic backgrounds. Now, we know that in the south end of Miami-Dade County, that people have been struggling for health care. What is the University of Miami doing so that we can do a couple things? One, that they will be included in this, because it's essential, all right, in Dade County and across the state and across the country, that people that haven't got much medical care, that don't like to go to doctors, all right, that may have diseases that they're unaware of, all right. What's the outreach program for those look like?
The outreach program is, I think, like in all of us, in many programs, it starts by rebuilding trust. If you don't have trust, you don't rely on somebody. You don't seek a service if you don't trust who is going to perform that service, right? And you want to be inclusive, representative. So that's how we do. Again, we go to the community where they are. We listen to their needs. We listen to the reasons why they decide to seek medical services or not. What is the uptake, right? And we try to, I will not say to fix it, but to find ways to mitigate it. So we go to those communities. If somebody doesn't have healthcare insurance, they still can participate in projects like the All of Us.
So the University of Miami has a excellent reputation, all right, and a great football team most of the time, but they have a great reputation as far as doing things for this community, all right, and across the country. So my hat's off to not just the current administrators and the current students, but the alumni that help make that happen, and great people like yourself. So if somebody wants to participate, what do they need to do?
They need to go to our website, allofus.gov, and they can register there and follow the instructions. Right. And there's we have also on the screen, we can put the phone numbers, the email address, where they can find the details of how to enroll, and we can assist them also in the process.
So somebody can go on look for All of Us research program, University of Miami. It's everywhere, all right? You do a wonderful job with that. My hat's off to you and to our studio audience over here for making this happen. Professor, thank you very much for you do and for making a difference, all right? You really have.
Thank you.
And
thank you.
And I want to thank the university for making sure that you're there to help. Again, our guest today.
Pleasure.
All right. Why don't you tell everybody, pronounce your name so we get it right.
It's Rosario Isasi, and doesn't matter how you pronounce it. It's okay.
Oh, yes, folks.
We embrace diversity. So.
Okay. So listen, today is what? Today's Monday, 9:45. You want to find out about the program. It's really, you can help not just yourself, but your family, the city, the county, the state, and the country, and in some cases, the world. I want to thank you for joining us, and thank you, and have a good day. Professor, thank you so much.
Thank you.
Always a pleasure.
That was a pleasure.
Okay.
Thank you.